COVID-19 pandemic, you can see that in 2 years we have already passed, but we are still grappling with this COVID-19. And according to Bloomberg, I just checked an hour before, so 339 million, in fact, are reported as COVID-19 cases. We know that there are a lot of debates going on, and COVID-19 deaths happen globally, over 5.5 million deaths. And but can you imagine that you are all experts that science and innovations are going up, increasing day by day, but the simple virus, the way it has affected the health system and also the consequences we can see in the social arena, in the economic arena, in education, whatnot, even in our psychology. So everything is being disrupted. But day by day, I think we can learn better that we are in 2019 at the end, and now we are in 2021 in January. I think we have learned a little better, but still I know that there are a lot of challenges. And we are thinking of future health system. So I hope that in this session, what we would like to better understand, also to discuss that what is happening globally and also regionally with COVID-19 infections. Especially in our discussion, we would like to hear more on the impact on children, mothers, and how the government and the health system, international community and local community responded, and which responses worked better, which did not work, and what lessons we have gathered over this time in shaping our future health system. And that health system, I hope that it is not only going to be restrictive to only health system, it should be going beyond what we are. So with this, I would like to actually start with the first presenter. So the first presenter is going to speak on, you'll see the title, but I would like to say that it's on the global COVID-19 epidemiology and impact on children and what we have done so far. And today's speaker, I'm also delighted to introduce Professor Zulfiqar Bhutta, who I know for a long, long time. And he's the Robert Harding Chair in Global Child Health and Policy Center for Global Child Health. It's in the Hospital for Sick Children, University of Toronto. But more importantly, I know that Zulfiqar Bhutta is our pride. He's from Pakistan, and he's a distinguished university professor and founding director of Institute for Global and Health and Development, Aga Khan University, and which includes South, Central Asia, East Africa, and United Kingdom. So with this, I would request Professor Bhutta to start his presentation.
Thank you very much, Kaosar, for that generous introduction, and I'm delighted to participate in this session with one of the world's leading institutions in public health. I'd like to just confirm that you can actually see my slides.
Yeah.
So what I would like to do over the next 15 minutes or so is principally talk to you about what we have learned so far about global COVID epidemiology and impacts in children and women. And it's based on empiric work that's been done over time. And it's amazing, as Kaosar was saying, that at this stage of the pandemic, when we are approaching 2 years of it, that we've got almost 5.6 million deaths worldwide documented from this disorder. Close to around 339 million cases have been documented, and no country in the world, no region of the world has been spared this. And these numbers that you see in front of you are probably underreported. And as the Institute for Health Metrics and Evaluation tells us, that the percentage of underreporting, just given the fewer number of tests and limited diagnostics, is probably much greater in low and middle income countries. And as you can see here in Africa, we have very little information on population epidemiology of COVID. And the same is probably true for underreporting in South Asia, although the magnitude of that may be debatable. So we probably have had much more than we can recognize from global stats at the moment. At a very early stage of the pandemic, I put together a group of people that I would like to acknowledge as the people behind a lot of the scholarship that's been done. This COVID working group that I established was a multi-country, multinational group of people who represented various stages of their academia, postdocs, master students, as well as faculty members, spanning many geographies where my institutions work. And I'm very grateful to them for a lot of the product that has come out of this deeper insight into COVID-19 for women and children. So let's start with the mother. So we put together this systematic review that was published a few months ago on the impact of COVID-19 on women, particularly those in pregnancy. And as you can imagine, in addition to what the mother might experience herself in terms of morbidity and complications, a big focus of where we thought we ought to be looking at adverse outcomes related to pregnancy outcomes for the baby, both in terms of prematurity, also in terms of intrauterine growth retardation and pregnancy complications. We looked at a lot of the literature, and I'm summarizing this meta-analysis that looked at 62 studies, a number of them from low and middle-income countries, but a large number also clustered in high-income countries. At the time when we reported this, it had about 31,000 cases of infections with COVID-19 in pregnancy. And to summarize a lot of the findings, if you had relatively severe disease in the mother, severe COVID-19, you had adverse outcomes in relation to both the pregnancy itself, including risks of preeclampsia, but also adverse outcomes in the newborn. And this can be reflected in both ICU admissions as well as perinatal mortality. This was probably best documented by our inter-COVID study, which was a multinational cohort study from various geographies. Published in JAMA, and you can see very clearly that these survival curves of gestational age at delivery, with or without COVID-19, very clearly shows you that there is a higher propensity for prematurity, reflected in this blue line, in those who had symptomatic COVID-19 in pregnancy, compared to those who are either asymptomatic or did not have COVID-19. It was also reflected in the severity of outcomes. So if you look at severe perinatal mortality and morbidity index, reflected here with a reference value of those mothers and babies who were not COVID positive, if you were diagnosed and if you had a test positive newborn also, these risks of adverse outcomes, severe perinatal as well as neonatal mortality, were 3 to 4-fold higher in that subgroup. So it's not an innocuous disease in pregnancy. And that's one of the reasons why from a very early stage, recommendations for vaccination in pregnancy came about. But regardless, we put out with UNICEF some clear guidelines that were important for managing babies and newborns. And they reflected several things that we thought were important from a public health perspective. Firstly, we said universal screening for COVID-19 should be offered to all pregnant women. The importance of psychosocial support, the whole issue of mental health in pregnancy, and then importantly, keeping the mother and baby together. In the early stage of the pandemic, there was a lot of disinformation on separating the mother and baby, putting the babies in isolation, not breastfeeding them, and every recommendation that has come out on the basis of science and summarized last year in March by us in this document in collaboration with UNICEF and USAID suggests that you don't need to do that. So for low and middle income countries, the most important thing was to keep the mother and baby together and be watchful, but without overreacting in terms of looking at risks of adverse outcomes that people were very concerned about. I would like to turn now to children and what do we know about COVID direct effects in children from the global literature. These are data that we summarized at the end of last year in looking at what did we know from various countries in the world about case distribution and also mortality. And as you can see, it's an inverse pyramid in terms of mortality. Very little mortality in children, even though the number of cases in children are notable. They're not as high as that in adults and elderly, but they're notable. But mortality and case fatality rates are extremely low. And in general, these have been less than 1%. Over time, we have been able to add to that database. And if you look at the age group under 5, as a proportion of global deaths, these represent less than 0.1%. They become a little more notable as you grow older, and particularly for adolescents, they begin to climb. But by and large, case fatality rates remain extremely low. And as you can see, that this has remained the case throughout the pandemic, and particularly so in young children under 5 and in adolescents 10 to 19. There is now a lot more data on this available from the Omicron wave. These are recent data from the United States, where one looks at the prevalence, and of course, with the wave and with a large proportion of unvaccinated children in comparison, the caseload in children went up. Lots of cases in children, lots of children in hospital because of symptoms, particularly fever, and through an abundance of caution. But what is very clear is that it has not been associated with excess mortality. So mortality rates, despite the numbers in children in the US, with almost 99% of the data captured, remain very low. So as you can see here, the deaths are virtually negligible in this age group, although it can take place. Very recently, just last week, these data came out of the UK for the first data on Omicron, on looking at what has been the mortality by age groups in children with various stages of the pandemic. So as you can see here, from 2020, first half to the latter half of 2020 and 21, and look at this last period as being probably related to Omicron. And very clearly in young infants, where people were very concerned about this being more severe, there isn't an excess mortality in this age group compared to other periods at all. So it has been quite notable that this has not been a severe illness insofar as high-income countries. But the big question arises if this is true globally. And that was a big focus of our own group's work. So as I said, we put together a number of reviews, both for multi-inflammatory syndrome, as well as the epidemiology at different stages with UNICEF and other organizations. And this large systematic review that was published earlier on last year on looking at children in particular. And there's a lot of data to go through, but it represents now a reasonable mixture of information from high-income countries, middle and low-income countries. But the important thing for you to note is that Africa has very, very few reports of children. Now, what can we summarize from this? First of all, if you look at the distribution of deaths from the 67 series of pediatric COVID-19 that we looked at, the bulk of these are in older children or adolescents. Very little in children under 5 and school-age children. Not to say that it cannot happen, but it is proportionately less. But there are some very important differences between high-income countries and low and middle-income countries. And this is a comparison of about equal number of studies, although the number of patients in LMICs may be lower. And you can very clearly see that access to care, ICU admission, mechanical ventilation in low and middle-income countries for children hospitalized, relatively lower. And if you look at case fatality or mortality, about double the mortality in children in low and middle-income countries. 5% is much higher than the global averages that I've talked about for children. And you see the same case with multi-inflammatory syndrome. There is relatively lower access to intensive care, to ventilation, given services, and about a 3 to 4-fold higher case fatality ratio in children who are infected with multi-inflammatory syndrome. So clearly health systems matter. And if you don't have access to good care, if you don't have access to special care, to oxygen, to services, to follow-up, then you cannot expect the same outcome as you have in high-income countries. So it is not an innocuous illness or an innocuous disorder across the world. And one therefore needs to look at mitigation and prevention strategies. So to summarize those findings, children who have had adverse outcomes, like adults, have been generally those who have had comorbidities. We do see a higher proportion of adverse outcomes, severe disease and mortality in LMICs, but as yet we do not have any information to substantially reassure us that long COVID is not a problem in children. And this is something that we need to be cognizant. The good news for many people would be that despite the significant increase in pediatric admissions and cases recently, both the Delta wave and the Omicron wave upsurge has not changed the disease severity and complication rates in children. Right, what about indirect effects? So I'm going to share with you some of the data from our recent study, began with UNICEF in South Asia, looking at both direct and indirect effects of COVID-19. And I've already spoken about direct effects, so I'm going to restrict myself to indirect effects. And as you can imagine, in our region, in South Asia, COVID has had several waves. We are right in the middle of the fourth wave in many places, with very high rates due to Omicron and a very steep rise in cases. If you look at the corresponding case fatality rates, fortunately, the region, like other places, has not seen an upsurge in both daily confirmed cases and case fatality rates. But the region put together mitigation strategies, which are captured in this stringency index from a very early stage of the pandemic. And I'm showing you this complex graph to make a couple of points. Firstly, at a very early stage of the pandemic, by about March, almost everything had closed down. Schools, businesses, even movement restrictions. And you can see that by the universality of that stringent measures. It opened up then differently in different countries of South Asia, these 6 countries that I'm summarizing here, including Bangladesh, all different. But you can see that there has been a lot of waxing and waning. And in particular, as you will see from what I'm going to show you, keeping schools open has been a big challenge in the region. So one of the first things that happened was that schools closed, as I said, and this series of graphs will show you exactly how it changed from almost universal school closure to periodic opening, and then some debate on whether they should stay open. And even now, despite the fact that there has been improvement, school closures are still being seen in many places as general response to the pandemic. And that's been very unfortunate because schools have had a major role in child development beyond education. And we are beginning to see some of those consequences. In our report, we go through a number of indirect effects that can happen because of these stringent measures or mitigation strategies. I will not talk about health services only, but particularly in relation to interruption of food supplies, food insecurity, economic activity, but especially disruption of education at a critical stage of child development, and particularly for girls, has this potential risk of pushing them out of the education system altogether. In other words, complete permanent dropout of girls from education. And we believe from our data and modeling that that's actually happened in the region. In terms of the coverage disruptions from health systems, these are actual data. These are not model data from South Asia, from DGHS, including data from Bangladesh. And as you can see, over this entire 4 periods that I've mentioned here, right up to the second quarter of 2021, there has been a significant disruption in both nutrition treatment, care seeking for pneumonia, and vaccinations. And although things have recovered somewhat, they have not recovered to the extent of pre-pandemic services, and maternal services in particular remain quite interrupted. The impact of this on mortality estimation is not small. And in many instances, our modeling and data indicate that there may have been close to around a 10 to 12% increase in excess deaths amongst children. They are not large enough to be recognized readily as direct or indirect effects related to COVID, but these are what has happened in the region because of a variety of interruptions. Education, I've already mentioned to you that this really impacts more than 9 million children in terms of risk of dropping out of school. And disproportionately amongst the poorest households, which have not had access to either remote learning. And the impact in terms of years of education lost is estimated to be at least 7 years in some instances, particularly amongst the poorest of the poor. In girls in particular, we believe that close to 4.5 million girls have been have dropped out, and some will never come back because they will be married off. You can imagine in our culture what happens to a 16, 17-year-old girl if she's sitting at home for up to 2 years. And this will impact particularly both with the excess increase in adolescent pregnancies and adverse birth and child outcomes. And in this particular slide, estimated for various countries in the region are both the increase in adolescent pregnancies, maternal deaths, neonatal deaths, and impact on low birth weight and small for gestational age births. So I'd like to summarize by saying that this was reasonably well predicted. And in a very prescient statement by UNICEF that I'd like to acknowledge from March 2020, when the pandemic was declared, was that children may not be the face of this pandemic, but the risk being amongst these biggest victims, as their lives may be changed in profound ways. And I'm just quoting verbatim from that report. When it came out, people said, UNICEF is scaremongering, but they were not. And they also pointed out that this would impact all ages, all countries, and they may be impacted by the very mitigation measures that we put in place that may inadvertently do more harm than good. It was a universal crisis, and for some children, the impact may be lifelong unless we act and do something about it. And the whole issue of the inequity around this. So, ladies and gentlemen, to summarize, in my own assessment and my group's assessment of the pandemic, the indirect effects of COVID-19 on the lives of women and children may be far worse than the direct effects. And our data from both communities, population level, and educational settings so far show that although the younger children may have a lower susceptibility to SARS-CoV-2, but adolescents, particularly high school children, have almost the same risk as you observe in young adults. And we need mitigation strategies for not only addressing the gap that has been introduced by the current pandemic, but for future pandemics. I don't think we should ever again close schools and induce what is really an artificial crisis of learning deficits and mental health issues of the kind that we have seen over the last 2 years. And this requires a global consensus in terms of future strategies to address these kind of issues. And of course, we are some of the biggest advocates for making sure that we immunize children adequately and in large numbers. So thank you very much for your time. And I'd be happy to take any questions now or later.
Well, thank you so much, Professor Bhutta. I think that we have already passed time, but I have a quick question to you. That do you have any data that you also measure the differences of inequity exist between the developed and low MIC countries, middle income countries, and the upper income countries? Yeah,
so that's a great question. I mean, and people have been looking at inequities across various contexts, particularly Michael Marmot has published on this recently. And it has affected everybody. Some of the most egregious effects of COVID-19 in terms of inequities, both by race, gender, color, and socioeconomic gradients have been observed in high-income countries. But they also exist in low-income countries. It's just that we don't have the data readily available because very few population surveys with socioeconomic gradients have been undertaken. But the data that we note so far indicate that in large urban populations, particularly, the inequities are very notable. Fortunately for many low and middle income countries, India being one exception maybe, this has been largely an urban pandemic. It has not impacted rural populations in the same way, possibly because of lower risks of congestion and people-to-people contact. And that may be one mitigation measure in terms of the usual urban-rural divide that we see. But to answer your question, inequity in terms of access to services and impacts is universal, and it's been observed in both high-income and low-income countries.
Thank you so much. I think we'll go to the next presentation, which will be Professor Dr. Syed Mansoob Murshed will be presenting, and his presentation is on populism and the COVID-19 pandemic. So over to Professor Murshed.
Okay, thank you very much. I'm, greatly honored.
Can you go to your first slide? Can you go to your first slide?
Don't worry, that's what I'm trying to do.
Okay, thanks.
There we are, full screen. Okay, so thank you very much for having me. I'm, as they say in the Monty Python shows, this is something completely different. I'm not a medic. I'm one of the bad guys. I'm an economist, and I'm interested in political science. And this particular presentation I give to you today is based upon joint work with a number of co-authors who are both economists and interested in political economy. So we're interested in the political economy of COVID-19, particularly, how it's impacted on countries when we control for their political system or the nature of their government. Okay, so that's what I'm trying to do. So what we are dealing with is something which is a mouthful. Yeah, okay, it's called populism. So populism is different from a political orientation of the government, where the government can be described as usually either democratic, or autocratic, or another mouthful, a mixture of the two, some elements of autocracy combined with some elements of democracy, particularly weak constraints on the executive, which was traditionally defined as something called anocracy. So the term sort of emanates from anarchy, a little bit of this, a little bit of that. Okay, so one of the motivations we had was, there was a number of studies which came out which looked at the differences between an authoritarian state like China and Western democracies and how they responded to the pandemic. So there's a lot of work on that. But there was a gap in the literature on a type of governance which can be described as populism. Populism is neither authoritarian nor democratic. It basically means a thin ideology, which is kind of ill-defined, but in developing countries is associated with excessive nationalism, also in developed countries. So the populist leaders profess to express the general will. So they're basically, there are two, I think, salient features of populism. One is a scant respect for the rules, okay? Scant respect for the processes, the legal processes in the Constitution. The other mirroring that is basically, skepticism for scientific advice, okay? So ignoring scientific advice. Okay, so essentially populism is going to respond differently from an autocratic state. So for example, China is an autocratic state, but the present day ruler of Brazil, the president of Brazil is classified as a populist, okay? Which is different. So Donald Trump would be a populist. He's probably one of the best examples of a populist state. By the way, in this kind of empirical analysis, India is considered to be a populist state given its present dispensation, its government. So the background for the rise of populism is economic globalization and the inequality which inevitably accompanies greater globalization, particularly of the type that we've seen in the last 40 years. Okay, so my own take on this is that populists are also plutocrats. They're not like the traditional populist government in countries like Argentina, Peronists, who represent the poor. They are not particularly interested in reducing inequality in society. Okay, so we want to see, given this background, we want to see how populist governments responded initially for the period in the year 2020 to the pandemic. Okay, so we're doing something different from the rest of the literature, which focuses on either, you know, democracies in Western Europe or, say, authoritarian states like China. Okay, so, all right, I've said that. Basically, our setup in terms of, which is something, I don't know the orientation of the audience, but in terms of political economy or economics, we want to look at the interaction between the state on the one hand, the governing group on the one hand, and the members of the public. Okay, so our basic, you know, prior over here is that a populist government ignores expert advice or is more skeptical about expert advice. So it will be more reluctant to take action, things like lockdowns or whatever. We're talking about 2020, really, that's our data. At the moment, we are confining ourselves, our analysis to the year 2020, the first year of the pandemic. So we're postulating that they are less likely to impose lockdowns and restrictions. Plus, being sort of most populist governments are right-wing, so that also will make them a little less willing to impose measures against the pandemic, particularly lockdowns. Okay. So essentially, I won't bore you with this, but there are two states of the world here, one with higher infections and higher mortality, and another state of the world with lower infections and lower mortality, which is, and that depends upon the probabilities of the good and bad outcomes depend upon actions and efforts. Actions by the government, which is denoted by A over here inside the utility, the right-hand side of these equations, and efforts by the public. So essentially, turning to the public, also you have a similar set of outcomes. Probabilities of good and bad states depending upon the amount of effort and action undertaken. The important thing to take away from all of this algebra, and I did this algebra despite my promise to myself not to do algebra in public, but it is to show the kind of interdependence, okay? So the state of the world depends upon actions taken by the government, A, and efforts undertaken by the public. So the way we show it is in terms of reaction functions, and in response to the pandemic, the reaction function of the state will move, and then there will be a new equilibrium from A to B, requiring more efforts such as social distancing, mask wearing by the public, which is shown on the vertical axis, and the horizontal axis, more actions by the government. So our postulate is that, our hypothesis is that populist governments have an aversion to lockdown because they ignore, because A, they're plutocrats, and B, they ignore expert advice. On the other hand, everything depends upon how the public and the government react with one another, okay? So these are our empirical hypotheses, which I've already mentioned. So what do we find? So what we're looking at is 42 developed and developing economies on which we have data on all the variables of our interest. So basically, we're interested in excess mortality. So that's one set of data which we get from the WHO database. We code countries as either populist or not populist. But where do we get this information from? We don't just cook it up ourselves, we take it from a data source which is known as Populist. So during the beginning of the pandemic, very importantly, the United States was a populist, was ruled by a populist government, if you like, because of the presidency of Donald Trump. The United Kingdom is coded as populist. Other important countries which are coded as populist include Brazil, India, one or two countries in Eastern Europe as well, and quite interestingly, the United Kingdom as well. Then we have information on government response, the COVID-19 response tracker, which was in a source of data which Professor Bhutta also used, which was on, the subtitles of some of the data he gathered. Then we have the behavior of the state, citizen mobility, moving about during lockdown, observing or not observing lockdown. So where do we get this information from? We get it from a Google COVID-19 database. We also have a number of control variables, which I will not go into, like the health facilities of the country, the degree of inequality within the country, and so on. I won't present to you our statistical econometric analysis, which will take a very long time, but some of the descriptive data. So we have weekly data, okay? Policy response, infection rates, mortality, and so on. So this is the policy response from the Oxford Policy Response Tracker, which we control for pure autocratic measures. So here we've controlled the data, we have changed the data and taken out policy responses which may be simply regarded as power grabbing by the state, using the COVID-19 pandemic as an excuse. So we've omitted that kind of data. So you can see the green line over here indicates populist states. So populist governments enacted fewer measures, and we have other data where we control for infection rates, and our results are then are also born once we control for infection rates. In other words, when infection rates are high, populist governments still enact fewer policies. And the same thing is true about the public's reaction. So it was, I've just come into, today I traveled between the United Kingdom and the Netherlands, and I noticed a great difference in public compliance to wearing face masks. And in the United Kingdom, it's rather indifferent. About 50 people on public transport will use, 50% of people will use face masks in the United Kingdom. In the Netherlands, on the other hand, the compliance is almost 100%. So this is data on citizen mobility, moving around during lockdown. And again, once the green line indicates that in populist-run states, the public is less observant of lockdown via the green line. And as you can imagine, the excess mortality will also be higher, at least for 2020. We are going to do future work on citizen mobility, where we're going to interact the past history of the nature of government, particularly because in Europe, at least the former communist bloc, we find greater reluctance to engage in prudential behavior by citizens. And we have data on it, and we are going to analyze that. But I'll leave it over there, and thank you very much for having me. And I look forward to the next speaker, and I'm hoping it will represent yet another discipline. Thank you very much for your attention. I shall stop sharing my screen.
Thank you, Professor Murshed. I'm so sorry that I did not introduce you, that who you are. Actually, you are one of Bangladeshi, right? A long time before you're in Bangladesh. But now you are a professor at Erasmus University, or also Coventry University in UK, and Erasmus in Netherlands. So many of us actually also know you through your work. Thank you very much. And but we can see that, this the discussion that you raised about this populist government, even the Democrats, even the autocrats, we can see that, in this specific period, only one or two countries probably were able to manage or handle COVID-19, quite efficiently. So we can see that most of them are autocratic countries, right? According to our definition, maybe they're
that was the initial.
Yeah.
That was the initial kind of analysis coming out to say that autocratic countries like China handled it better. So we wanted to look at something completely different. China is not an autocratic country. It is not a populist country. It's autocratic, I beg your pardon.
Yeah.
And Russia is also an autocratic country. So traditional autocracies, there's much more, they may be autocratic, but they don't ignore expert advice. The anti-elite kind of tendencies of populists are absent in autocracies.
Yes. Thank you. That we'll learn more from you during our discussion. Thank you very much. So I'm going to come to our next presenter from Bangladesh, who's basically based in Bangladesh, Professor Dr. Be-Nazir Ahmed, who is the country lead of ASEAN Bangladesh. And he was the former director of the Disease Control of Director General of Health Services, Ministry of Health, Government of Bangladesh. And I also know him very well. So I'm going to request Professor Be-Nazir Ahmed to make his presentation on Bangladesh's government's response to COVID-19. So over to Professor Be-Nazir Ahmed.
Thank you. Thank you, Professor Afsana, and thank you, the other two speakers. I actually enjoyed and learned a lot. Really remarkable presentations. So actually my presentations will be limited to the response of the government of Bangladesh to COVID, some pros and cons. So let me start with actually the involvement of COVID. Though actually in the scientific community, it is more or less in consensus that the virus has emerged from the bat, ultimately through pangolin to human. But still there are some debate on that. Actually, it is unprecedented over 100 years, maybe up to the 2018 pandemic of influenza. After that, we actually came across several other pandemics, mainly due to influenza. And the last one in 2009, due to the so-called the swine flu pandemic or H1N1 pandemic. But actually that was mainly unnoticed. In general, people, even the people of other discipline other than some of us who are directly involved in handling that pandemic. But this is unprecedented. Why this virus actually became so dangerous and actually it is surpassing all the speculations and all the actually thoughts of the scientists, of the public health association and others, that how actually it would behave from its emergence in 2019, maybe December. And actually still now, after about 2 years, more than 2 years, we cannot actually tell that we are seeing the silver line at the end of this pandemic. And WHO DG actually rightly mentioned that this Omicron variant may not be the last variant that will evolve in this pandemic. So it actually happened like that from China 1, it actually goes to countries all over the world. And the pandemic actually evolved like that. A small outbreak in China 1, then it has spread to other parts of China, then other countries of Asia, Europe, then in Asia, North America, South America, Australia, other countries, and actually ultimately the pandemic established. And still, we are going through it. So actually there is a question, why it is happening like that? And only maybe China is the only country who actually was able to handle it properly. Though Australia, New Zealand, they also did marvelous job in containment of this pandemic. But in spite of that, this question is actually sometimes coming that why actually the virus becomes such that it didn't happen earlier, other than we can say SARS earlier and a little bit MERS coronavirus. But that was not up to that magnitude. But this time, why? So this question actually compel us to think more and more and learn in our lifetime for actually pandemics in the future. So this is the present situation now. I presented one actually seminar in Dhaka University in April 2020. And during that time, there was a projection from University of USA that maybe 486,000 people may die in USA alone. During that time, when I presented, I didn't believe, but it is now the fact that such number of people really died in America. Anywhere it can surpass. So, and in the world already, you all mentioned about the number of cases, number of deaths, and what has been being now done by the Omicron variant, we can see at a glance in this slide. So I am going to actually Bangladesh perspective mainly. So regarding the response of Bangladesh in containment and vaccine delivery, there are a few areas. For the containment, Bangladesh worked on screening. Actually, it started with screening at the point of entry. That actually I established a little bit during the Ebola outbreak in the African countries. We actually extended the screening at point of entry under IHR 2005. And actually that was extended subsequently. And first we started with this screening at the point of entries, mainly at the Dhaka International Airport, then in other two international airports, and a little bit at seaport and the land port also subsequently. So the other measure was quarantine, especially when the outbreak occurred in Wuhan. The students mainly studying in China were quarantined, and I think it was done more or less successfully. But subsequently, we actually tried for quarantine, especially people coming from Europe. I remember people coming from Italy, the Bangladeshis working there or staying there, and people living in other European countries. But in fact, we couldn't do the quarantine successfully as it was required. Regarding the testing, it is still today, some actually journalists ask me, what is the situation of testing now? So when we started, you remember, we started only just with one testing center with RT-PCR in IDCR. And that was for 180 million people. And it was a ridiculous thought during that time to go with just one center, though subsequently the number of centers increased a lot. And also along with PCR, after a long time, the antigen-based rapid diagnostic test was introduced, but still it is not up to the requirement. And many of the people are not actually doing the test for COVID. And isolation also didn't happen well. We couldn't isolate the people. And that was actually really area that actually helped or that was responsible for the wide spread of the disease throughout the country at various times. This isolation, mainly it was a suggestion or advice over telephone to get isolated at home. And really that didn't happen. That didn't happen for many reasons. And the other measures, you can say the widespread measures, were the movement restriction in the form of, you can say, the lockdown, usually popularly known. And that was done quite a number of times and over a span of period. And management of the patient, that is another area. Actually, we, at the first stage, started with few actually management center, especially in the government sector. And actually during that time, the private sector didn't participate. And gradually the number of centers in the government sector increased, but with a scarcity of oxygen and actually other amenities for management. But ultimately it come up, and I think Bangladesh did well ultimately for management of the patient. And regarding the vaccination, we have started well. We have started with procurement of vaccine and contracting with the Indian company especially. And during the initial phases, we are at a position that we are few of the countries in the world having vaccine. But ultimately it didn't go well. And actually mainly due to, one is the scarcity of vaccine globally, especially the company, which is Bangladesh had a contract, didn't supply the expected amount from India. And we actually didn't have much contract with other companies or such relation that we could get vaccine from other companies. Though ultimately Chinese company ultimately contributed a lot. Subsequently, we got vaccine from other initiatives, especially the COVAX initiative, and actually WHO and other organizations. They throw their cooperation. Bangladesh has started to get vaccine from various countries. And ultimately, the vaccine supply, you can say, more or less satisfactory, but there are issues of campaign that the vaccine campaign, especially at the city, it was good, but for the rural areas and the urban slums also, the campaign didn't go well. I shall tell a little bit in details. Bangladesh actually drafted a plan for prevention and control of COVID. And these were the main budget lines. The most important was the coordination, and ultimately didn't went well. If we tell about the stewardship, the coordination, integration, it didn't actually go well. Even now, the coordination, the leadership is not up to the mark. Regarding surveillance, outbreak and contact tracing, there was, this was another actually strategic approach, but it also didn't work very well. Regarding the laboratory diagnostics, I told you already about this. We actually suffer still with scarcity of testing. Probably Bangladesh, one of the few countries having the lowest number of testing. Suffering in China, for 1-2 cases, they will actually plan for million testing, 100,000 testing, 200,000 testing. But in Bangladesh, it is actually the different, that for million cases, we may test for 100,000 like that. Case management, including patient transfer, it actually suffered at many times, but ultimately we could manage, especially as the number of admission was not that much in comparison to number of cases due to maybe younger ages of people in Bangladesh mainly. But in spite of that, especially the ICU facilities and others, people suffer a lot, and oxygen supply also was not up to the mark. Regarding infection prevention control, including waste management, this was another strategic approach, but it didn't also work well. regarding the point of entries, we did to some extent, but if we think about the expected quarantine, it didn't happen. Many times there are breaches, and actually that helped to spread the disease among the communities. And the last one, public awareness, media and communication, that didn't work well. Actually, a lot of misinformation, lot of contradictory statement, and ultimately people, it was difficult for people to believe which one is the best and which one they should follow.
Sorry, Professor Be-Nazir Ahmed, I think you need to finish it soon because the time is over. We have, yeah, please.
Okay, I should not take much time. So which responses worked and which now? Responses that worked, actually movement, restriction, lockdown, I think that worked ultimately. And it was for a long time, but it ultimately, it could bring down the cases and ultimately contain the outbreaks. And there was gradual improvement in management of the cases. The response that didn't work is that quarantine, testing, isolation, I already mentioned. And also regarding vaccine delivery, registration over online registration, that was actually really difficult for the rural illiterate people. And limited number of centers at the onset of the campaign, it actually affected in the coverage and sometimes unavailability of vaccine. Who are left behind? I think mainly the rural people, elderly, illiterate people. They were left behind, especially in terms of diagnosis, they couldn't actually access, and also in terms of vaccination. Still, many of the rural old people, they are unvaccinated. We are going for booster doses, but they didn't get even the first dose. And we limited to only Upazila health complexes. We didn't use our community clinics or the health assistant in the earlier phases for registration and vaccinating the people. And regarding the response of the community, actually inability to participate due to non-involvement, like the member of parliament, elected local representatives, political parties, civil societies, and community engagement was not there. And actually more dependence on administration, that was the thing. So the conclusion is that there has been examples of nations doing badly and excellently with COVID-19. In Bangladesh, reported cases and fatalities are comparatively low, but we had the potentials of doing better. Still, we don't know what is happening. We need to organize ourselves faster with evolving contingency plans, resources, and implementation. Prompt and aggressive actions were warranted and all-out efforts involving all. Thank you. Thank you, Professor Afsana. Over to you.
Thank you so much, Professor Ahmed. Because of our time, we couldn't continue. And I'm going to go to the last presenter. I'm very delighted to introduce our last speaker, and she's the only woman among four, and Dr. Lilian Otiso. And Dr. Lilian Otiso is the Executive Director of Liverpool VCT Health, Kenya. And her presentation would be on how Kenya's health response adapted to COVID-19. Over to Lilian. Lilian, unmute yourself.
Okay.
Yes, thank you.
Are you seeing the slideshow or it's the displays? Are you seeing the slideshow or are you seeing my slide?
Yes, we can. Can you, we're just trying to reduce that next slide, the smaller one.
Yeah.
Just focus on your main slide. Could you do that? Thanks, Lilian.
I'm trying to do it and it's not working.
Okay, I think just proceed because we can see it.
Yeah, we can see it.
Yeah. No, it's not sharing.
Now you've got everything.
I can't see it.
Go to window. Go to your sort of slideshow. Go to slide.
Yeah. Can you just enlarge it? Zoom out.
You just need to go to slideshow. Yeah.
Zoom slideshow there. Okay, it's refusing to work, so I shall do that again, but I'll start talking. Yeah. So I'm presenting from the Kenyan perspective and specifically from LVCT Health, where I work. And LVCT is a Kenyan organization that has been involved in the HIV response for long. So we are, let me try that one more time. Yeah. Yeah, okay, so yeah, thanks. Okay, fine. So yes, I'm presenting from the work that we've done. We do a lot of work at community level involving HIV, gender-based violence, and sexual reproductive health. And we work closely with government and other CSOs in doing that response. So just to start off, as I'm the only presenter from Africa, I wanted to just give you a sense of where Kenya is, and that it is a country which has both rural and urban settings. We have slums, we have a rural population, but about 50% or rather the population that is in the urban areas, 60% are in slums. And that has a bearing in terms of what happened with COVID and very similar to the presentations and what we're hearing from Bangladesh and other countries. The Kenyan health system itself is a pluralistic system with both public and private facilities. And we have about 50% being public and 50% private, although in rural setup, it's public and majority of people do go to the public facilities. So when it comes to COVID in Kenya, just like many other countries, the graph is very similar. And you can see that the first case was actually diagnosed in around March 2020 and came with similar containment measures as we've just had from Bangladesh. But we've just had, or we are having the last wave of Omicron, and with cases increasing. But previously, especially with Delta, we saw a huge rise in the cases and a large number of people being admitted and this health system being overwhelmed, just as we saw with other countries. In terms of vaccination, we're only at 17% of the adult population in spite of different measures, but I'll come to that in a subsequent slide. So the response that was put in place by government, and this had a significant bearing on the populations that we serve, we had then a national curfew from 8 p.m. to 4 a.m. Then it moved on to 10 p.m. to 4 a.m. And this restricted a lot of movement at night, a lot of businesses that work at night, and it lasted for 1.5 years. So it just ended in mid-2021, and the effect on businesses was quite significant. There was the initial stay-at-home advice, but this moved. And then we had restricted movement in and out of counties, 5 counties, which had high prevalence initially. And then later to more zoned lockdowns. But we didn't have the full lockdown where you had to stay at home, but generally the restrictions in movement. And the significance of this was how people, for example, we provide antiretroviral therapy to clients who come from different counties, and they were suddenly locked out and could not come to access their care. Families were separated and stayed away, and we've seen cases where for example, a father stayed away from his family for the I think it was 2 months that were restricted. And in that time, one case, the father found that his daughter went off and got married because they needed someone to take care of them. We had school closures, as you saw from earlier slides, and that lasted for 9 months. So schools have been open since January 2021, and that has been helpful. But otherwise, a lot of other issues did come up that came up from the community. In spite of all that, there were some things. So as I said, we do work with government, and we've been working closely in terms of the response of monitoring how things are done. So there are certain things which were done well. And some of this is the multi-sectoral response, which included the public, the private sector, non-governmental organizations, and faith-based organizations. But the coordination was led by the government. Actually, there was the National Emergency Response Committee set up by the president that led the response. And community involvement was through community health workers right from the beginning. They were trained and provided resources to do this, although a lot of them also struggled just to get basic PPE, masks, and hand sanitizers, other than providing for themselves. There were national information campaigns, and even up to date, we still get daily updates from the Ministry of Health on the COVID status. Well, one thing that came through and from the work we did with Arise that was significant was recognizing who is vulnerable and the needs of the vulnerable. And so some like water was taken to the slums, and there was also some social protection fund. But the challenge was that the vulnerable had not been mapped before, and therefore there were very many people who are deserving who are left out because they didn't exist in any database. There were very good innovations in healthcare that came through, digital technology, so there's e-learning, and remote working. One of the unique things is even court cases up to now actually still heard remotely, so it really eased the process and made things more efficient. And teleconsultation, which is something which has also continued and grown since, and telecounseling since the COVID response. We also then built up on issues of local manufacture of PPE that wasn't there before, beds and others. And for the courier services to deliver drugs and people really not having to access care within the health facilities scaled up a lot. And for us, the clients I mentioned for antiretroviral therapy or pre-exposure prophylaxis would get their prescriptions filled and would send someone to deliver to them so that they don't have to come in. We also provided multi-month prescriptions for the chronic diseases. In spite of that, we had major challenges and gaps. Some of them were really to do with, I've already mentioned, accessing the vulnerable and how do you ensure that the vulnerable can get services. So this photo you're seeing here was taken by a participant from a photo voice study we undertook. And the message they were passing was that water was provided by different people, including government and other CSOs, but we forgot that people with disability and the elderly would struggle to get to the front of the line. And so they were left even far worse off than they were. Sex workers who are at risk of HIV and we work with really complained by not allowing businesses at night or movement. They were very restricted and suffered a lot of gender-based violence, resulting in death in some cases. Well, there was limited access to health services. Some maternities were turned into isolation units. And so especially the needs of women and children were quite affected. You couldn't just access health facilities as needed. And so that just informs that when you have such a response, what needs to be thought about that does not interfere with current services. Some commodities are still lacking from the system. For example, for the HIV program, viral load, the viral load testing equipment is the same one being used for PCR. And so the viral load testing has not gone back to the levels it was before. And we've seen increased teenage pregnancies. A recent study showed that this was even up to 2 times what there was before COVID. And the mental health challenges that have emerged in the community and health workers have also been quite significant. We had significant community involvement to help with the response. It could not address everything, but we really saw community health workers and others coming around to ensure that responses were addressed. People contributed food and other amenities to provide the needs for people. And we saw the community health work program getting more recognition even from government. For COVID vaccination, which has been driven by the government quite a bit, I mentioned that right now we're at 17% of adults fully vaccinated with a target of reaching about 25 million. So the vaccines have been received. We've received vaccines slowly over time. There was the challenge that we've all seen with developing countries not being able to access vaccines when we needed them. And so this has been slow. And sometimes you get those that are close to expiring, which poses big challenges. The main thing here we've seen that works is the community outreach and mobilization and going even door to door, especially in very rural areas to vaccinate the elderly. The big challenge is when the government or the facilities would say they lack resources to carry out those campaigns, and therefore they stay static in one place and you cannot get people to come. Some innovations around this, and they've come from some counties we work with, include starting the vaccination at say 3 p.m. and continuing until 9 p.m. and doing that in the marketplace or at the bus station so that you get a lot more people taking it up. And so those are some of the ideas and support that we're providing. But of course, there are challenges of some vaccine hesitancy. And therefore, government has put in a vaccination mandate. It's not being enforced fully, but it helps to drive up some of these numbers. So from December, we're at less than 5%, and now we're at 17%. So in summary, just the key messages are really that successful, efficient health system responses to pandemics require coordination and multi-sectoral engagement, and very effective coordination and being able to listen to each other and understand. This was start-stop, it was not perfect, but it was critical to ensure that there's one coordinated response. The community engagement is critical, and it helps to address misinformation, trust, and reach the vulnerable. One key thing that we saw here was that if the communities had been engaged earlier and the responses listened to, and we took the lessons that we had learned from HIV over the years on stigma and discrimination, some of the challenges we've seen with COVID would have been mitigated right from the beginning. And finally, innovation is important, and the health system must encourage and nurture innovation throughout, and not only coming from government sources, but from everyone across board. Thank you.
Thank you very much, Dr. Lilian Otiso, for your excellent presentation, especially that you have highlighted the role of community engagement and community health workers' contribution, which is recognized by the government. As we don't have that much of time, so I'll go straight to some questions that came in that question answer box. So can I pick up questions and come back to you? But I actually had questions for you. But let me see what are the questions that we do have now at this moment. So.
Do you want me to read out some, Sanapa?
That would be nice, Sabina, if you could help.
Okay, so one question, I'm just starting from the bottom. It's random, I apologize. So I'm going to just put out 3 questions. We literally have 7 minutes. One is, can you speak more to the status of mental health challenges for adults and children? And is there any work recognizing addressing mental health challenges in the population or in schools? Whoever's working in this can respond. Another one is, do you think democracy works better to contain COVID compared to populist autocrat governments? Finally, another question would be, what kind of misinformation has affected COVID response in the urban slums and refugee camps in Bangladesh? So this is a variety of questions. I just picked out a few because Afsana, literally we have 7 minutes. Sorry about this.
Maybe I can say something about mental health and then pass it on to my colleagues. So the whole issue of mental health challenges of COVID have ranged from things that have been very evident within families who've been constrained to stay at home, the rise in domestic violence, also the exposure of many young children to a constrained environment, which at that stage has been very challenging. So the exponential increase in the recognition and also the severity of mental health issues in families, particularly children, has been quite notable, and it's been very different from other pandemics because of the social constraints that many lockdowns have had. But it's also highlighted how poor services are, because even if you recognize them, what do you do about it in the absence of ambulatory services that are functioning and they have never been targeted towards adolescents and that age group? All the school health interventions have been also on school platforms. So what is emerging from all of this is the recognition of this area as being an orphan area. Secondly, the necessary mitigation strategies for it in the future. So my sense of optimism is that we will come out of this pandemic, certainly for children, with a much improved and much better school health, nutrition, and inclusive of mental health platforms that are potentially available to those who have otherwise been totally dependent upon the health system. And as you know, for many adolescents, accessing health systems which are adolescent non-friendly is very problematic. Thank you.
Thank you.
Can I just respond very quickly?
Yeah.
Basically our results show that, populist governments do worse in terms of both their response and in terms of outcomes, including excess mortality, than non-populists. Now, who are the non-populists? The non-populists are not necessarily democratic, because they can be autocratic states. They can also be democracies. A populist is usually, it's something different. It's not an autocratic state, but it's usually a leader who's been elected. So there's a democratic process taking place, but has less respect for the system, if you like, the constitution, if you like, the legal framework, if you like. Someone like Trump, okay? Someone like, you know, the present Prime Minister of the United Kingdom, who is very cavalier in his adherence to rules, right? Also, countries like Brazil and India at the moment are coded as populist. Okay, so these countries invariably were slower in responding, in taking public action, and the public action was more muted. The work of the economist shows that, you know, if you have like the kind of situation that we had 2 years ago when the pandemic first started, you know, there's no question of trade-offs between lives and livelihoods. You know, if you don't take action, you have a dark recession. You have a, you know, the economy's productive capacity is diminished. Now, there's other type of work which is taking place in parallel, which shows that, you know, the great increase in labor supply, which took place in the 90s because of China's entry into the world trading system. Even though we're not talking about the mobility of labor, but we are basically saying that China's labor supply became part of the world's production process. So there was an increase in the supply of labor, as well as other factors such as, you know, increased women's participation in the labor force resulted in an increased supply of labor, which tended to depress wages for unskilled workers relative to skilled workers. So that all might be changing. I mean, we're seeing things in the United States where there's a shortage of face-to-face service workers for the first time in 50 years or more. Okay, so we are seeing some changes. But basically, populist governments reacted more slowly. This is very clear from our analysis in 2020. And the public in populist governments also responded less prudentially. That's very clear.
Thank you, Professor Murshed. I think we don't have any time, right?
Anubhav?
We don't.
Only have 2 minutes, so
sorry that we may not be able to take any questions, but I know that we were able to speak, and I hope that we'll have interactions, and we can also send the questions to our presenters and connect to us, and then you can respond to us the questions we do have, and we can pass it to the people who actually ask questions. So I feel that, you know, from this specific session, we learned that the role of state is so critical. The state means, of course, the government, and beyond that, what we feel that as we are sitting in the in Bangladesh, in our country, we can understand that the global community was actually very slow, and we can understand the lack of partnership, which is very critical. And we have been talking a lot about SDG interactions, but we can see that global commitment is not only the WHO is committing on this, or UN is committing on this. I think it's a whole society approach, whole country approach. And if the big leaders in the world, if they are not coming up with the solutions that we need for the world, and in this specific pandemic period, it's very sad that how the big leaders at the global arena, they did not talk. As Professor Murshed clearly said, that the government who are actually populist government or autocratic government, we need to work together. The world is small, but the global world is not small. So how will be connected to that planet, the planet that climate is impacting on our health. The whole planetary health is so critical now. So we can't just keep ourselves within the health system. And we understand that in this specific time that we need to all work together, because in Bangladesh, we know how much we are pressurizing our people from the Ministry of Health. It's not only the responsibility of the Ministry of Health, it's the ministry of many ministries working together. And that actually didn't happen in one country. That means in the whole world, we have not worked together. And how we will be working together, that's the critical question to the researchers. And we feel that, time has come that we should do the transdisciplinary and interdisciplinary research and work with the policymakers at the global level, at the country level, and even bringing the community. I think community part is completely missing in this specific COVID-19. And we heard from Kenya, maybe Kenya is an exception, But Bangladesh, you know, how much you have taken, you know, our working shoulder to shoulder with the non-government sectors who are actually sitting there to give support. But indeed, they worked together, started working, but it was very late. And that kind of mindset should come out. Sustainable development goal is giving us more opportunity to work together. I hope that we will take this, you know, opportunities to make it into actions. And actions means to changing the life of the mother, women, children, and the most vulnerable populations in the community, in the world. I don't want to come to only to our own country, only to lower income countries. I think people in all the countries are actually vulnerable. So we cannot make it happen in future. The future is ours, and we have to take the challenges to come up with the better solutions. So I'll stop here, and I would like to give big thanks to all the panelists here. I think you made us today actually aware of many important issues that probably we are not aware of it. Thank you so much.
Thank you.
Excellent.
Thank you. Thank you.